will begin. Thank you again, everybody. And so I'll jump right in. So first, to talk a little bit about endocarditis in general, right? Endocarditis in general is typically a bacterial infection. The most common infections are organisms like Staph aureus and streptococcal infections, Enterococcus. The predominance of infections are gram-positive organisms. And so what I have done here is I have taken most of my talk is based on the work of a study that was done and published in 2017 on the epidemiology of endocarditis, in particular, how to diagnose blood culture negative endocarditis. So I will start with this background of, and in particular, there is a very well-known researcher. His name is Didier Raoult. He's at the University of Marseille, and he has been studying culture negative endocarditis for his entire career, over 30 years, and he's the most published researcher on the topic. So I use his research as the background of today's talk today. In one of the slides here, I have the reference to the article, which is the basis of this talk for everyone's reference if they wish to look at it after the fact. And so again, here is a culmination of several years of his research. This study included 918 patients who were sent to the hospital for a presumptive diagnosis of endocarditis over the course of 5 years, from 2010 to 2015 in the south of France. Of those 918, 635 had positive blood cultures, right? So they will not be the people that we're talking about today, right? But just so you understand that 2/3 of people who come who have a presentation concerning for endocarditis have atypical endocarditis that is readily identified and then can be treated. But then 1/3 of the patients, roughly, in this case, 280 something, had negative blood cultures, right? And so in that case, you think the patient has endocarditis, but you don't really know why. And we need to, what methodologies can we use to find those final diagnoses? Now, this study took those 283 patients and it applied the strict Duke's criteria, which is the standard methodology for the inclusion criteria for a case of endocarditis, and found that of those 283 patients who were sent because clinically there was some concern for endocarditis, only 177 of them actually had enough clinical evidence to suggest that they really had endocarditis. The other 106 patients did not fit the full Duke's criteria for endocarditis. So the remainder of this talk are going to be, what did they do for those 177 patients to try and establish a diagnosis for them, and what were the findings of that? Next slide, please. Excellent. And now, so again, at the end of all this, they put together those initial findings of the positive blood cultures plus all their additional work to tell us what they came up with, right? So the final distribution of endocarditis in the community is largely, again, gram-positive organisms like Staph aureus, Enterococcus, Streptococcus species, and then a small percentage of gram-negative organisms like E. coli and Pseudomonas, those type of infections. And then the cases that we're here to talk about today, which are some of the real blood culture negative ones, the obligate intracellular organisms like Coxiella burnetii, Bartonella, those types of infections, which we'll go into in much more detail. There are a small number of other infections in this category, would be things like fungal infections, tuberculosis, I'll talk about. And then occasionally there are non-infectious causes of endocarditis, which we'll go through the brief bit that they comprise. And then again, at the end, there are still a percentage of patients for whom we've been unable to find a diagnosis. So say, even with the best of intentions, diagnosis still in about 15% of cases still remains elusive. So next slide, please. So what are all the spectrum of things that you can find? So one of the things that we found is typical blood cultures, again, derive most of the diagnoses for endocarditis, but we can still find a lot of typical bacterial infections with more advanced methodologies. So what do you do with negative blood cultures? Right now, we can use and utilize various serology methodologies as well as advanced PCR technologies to find bacteria that are possible infectious causes, even though we don't grow them in culture. So one of the interesting things that I found, and what you'd be looking for here, are the organisms highlighted in red, right, which are some typical bacterial organisms that are found that didn't grow in culture, but through advanced technologies, we were still able to identify. So for example, one of the things that we have recently introduced in our hospital here for blood culture identification is when you incubate your blood cultures and the machine tells you that you start to have a positive results and that there are organisms growing, right? We gram stain that, and you typically then would find either a gram positive cocci or a gram negative rod or whatever it may be, right? And now we reflex that immediately to PCR technology that can readily identify hundreds of different organisms in real time in just an hour or so, instead of having to wait another 2 days to understand whether those gram-positive cocci are Streptococcus or Staph aureus or whatever, rapidly improving our time to treat. So one of the new technologies, one of the new ways of adapting that technology is to say, if you have somebody with a high suspicion of endocarditis, even though the blood cultures are negative, perhaps you can still apply this PCR technology to the negative cultures and come up with a positive identification, because that genetic material, if there really is Enterococcus in there or Streptococcus in there, will still be identifiable by PCR, even though there's not enough to grow on culture. So about a third of the results are able to be seen are able to be found by using this methodology. So next slide, please. Excellent. So now, again, with that, so again, this study took all those patients, the 177 unidentified high probability cases, right? And they went with their blood cultures and applied multiple different modalities to attempt to identify these organisms. They applied PCR for both typical organisms like gram positives and gram negatives, as well as serology to see if you have antibodies to any of these atypical organisms, as well as PCR for many of these organisms. And as over the last 10 years, the ability to create PCR specific targets for multiple different organisms has exploded to the point that we are now, doing this for organisms and for diagnostics of disease all over the place. In particular, COVID has proven how well and how rapidly we can develop new testing along these methodologies. So what are some of the real atypical causes of endocarditis and for blood culture negative endocarditis that we find in the community? Coxiella burnetii, Q fever is one of my favorite and the one that I'll spend time on talking about today. Others include brucella. This study actually found no cases of brucella for almost 1,000 of endocarditis. The febrile and frequent cause of FUO can go on to cause endocarditis. And Bartonella henselae and Quintana, sorry, I made a spelling mistake there, are next most common. There are intracellular, acellular, mycoplasma species, as well as occasionally mycobacterium species that can cause endocarditis. This study also captured a case of Legionella endocarditis, which usually would be cause of pneumonia but in an instance like this has been shown to be proven by serology to cause endocarditis. And another very rare but long established cause of endocarditis is Whipple's disease, right? And so again, they found a case of Whipple's disease in the course of, but you can see only one case in 5 years. It's very rare, but it is real. And then there are a couple other non-infectious causes that we'll talk about briefly at the end. Next slide, please. So again, Coxiella burnettii is called Q fever, right? Is the most studied of the atypical culture negative endocarditis. Typically, it comes in several forms, right? There are several, it can infect multiple organ systems. Initially, there's an acute infection, which in rare cases progresses to chronic disease, including what we're here to talk about today, which is endocarditis. Most commonly, and the most available testing for Q fever has to do with serologic testing. So first, Q fever, where did that name come from? Q fever is named for Query fever. In 1937, in Australia, there was an outbreak of a febrile illness. They'd never seen it before. They didn't know what it was. It was in slaughterhouse workers in Australia. They could tell that it was an acute febrile illness, but they didn't know why. They didn't have the technology yet to identify it. Oftentimes people think that the Q in Q fever stands for Queensland, because Queensland was where in Australia the first cases were identified. But it really just meant query because they didn't have a name for what to do with it yet. Then it took a little bit more than a decade later, in about 1949, concomitantly in the United States, the CDC was investigating an outbreak in Montana, while in Britain, they were also investigating outbreaks of similar diseases, when they were finally able to grow the disease in culture and finally start to give it a name, right? And so the name Coxiella burnettii actually comes from the researchers who did the initial identification of it. So there was a researcher named Cox in the United States, so that's where the Coxiella comes from. And there in Britain, there was Burnett. They both published their results nearly concomitantly, and so eponymously, they've named the organism after the two discoverers of the disease, and that's where the name comes from. And now the life cycle of the disease is fairly interesting. It has two main parts. There's a phase 1 and a phase 2, right? Phase 1 is the active growth cycle of the infection, when it's living intracellularly and it's really producing new organisms. That's called phase 1. Then, and that's what happens intracellularly inside another living host. Then there's a phase 2 where the organisms slow down and they become almost spore-like, and that is the part that actually spreads the infection to another person. So this is an easily aerosolized organism. It exists everywhere in the world except, oddly enough, New Zealand. So not only is New Zealand great at keeping out COVID, but they're also great at keeping out Q fever. The reservoir of the infection is in multiple animals. The main human vectors that transmit it to humans tend to be domestic animals, in particular sheep, goat, and cattle. It can also be in dogs and cats. There are multiple other organisms, animals, and both reptiles and birds that it can live in, but these are the main organisms the main animals that humans come in contact with from which they may get it. In particular, this organism tends to accumulate in the placenta, right? So one of the main routes of spread is by aerosolization of bacteria during birth of other animals, right? So the parturient cat is a classic example of an outbreak situation where in a barn, a cat may be having babies, and the people who are working in the barn a week later will have a cluster outbreak of an acute febrile illness with pneumonia that ends up being diagnosed as a zoonotic infection with Q fever. And again, it tends to be asymptomatic in other animals and causing disease only in about half of people who are exposed. And again, the acute presentation of Q fever tends to be, again, like I said, a high fever. People also often get a transient pneumonia, and their liver tests tend to be elevated. They may even get some pain with hepatitis. Next slide, please. In a small percentage of people, Q fever is not cleared and becomes a chronic infection. So one of the things that I talked about earlier was the life cycle, as well as serology as the diagnosis for this. And I want to just spend a minute talking about Q fever serology, right? Because that's something that many of us may come in contact with, and the interpretation is a little counterintuitive of how you're supposed to interpret it. But now that you understand a little bit about the growth cycle, it makes a little bit more sense. So people who have acute Q fever, right, who have a pneumonia, who have hepatitis, who are in acutely with fevers, right, if you order Q fever serology, you will get both IgG and IgM to both phase 1 and phase 2. And the diagnosis of acute Q fever is diagnosed by an elevated phase 2 antibodies first, right? So not phase 1, but the phase 2 actually corresponds to acute infection now. And why is that? Because that is the sporulated form that was transmitted that the body sees first and develops antibodies to first. And so that corresponds with phase 2. The growth phase, when it is intracellular and replicating, goes along with phase 1. And that is what happens later in the disease when it becomes chronic in your body and is replicating within cells. So if you want to check somebody for chronic Q fever and chronic endocarditis that's culture negative, what you'll be looking for on your serology testing is not a high phase 2, but a high phase 1 antibody to IgG and IgM will be the diagnostic characteristics that you would look for diagnosing Q fever endocarditis. So again, interesting that phase 2 turns positive first and phase 1 second, but once you understand the life cycle, that makes much more sense. So again, the chronic infections that Q fever can cause are, of course, endocarditis is the classic one. Other endovascular infections are also well documented. And so this includes prosthetic infections as well. So not only endocarditis, but in particular, prosthetic valve endocarditis is a high risk for Q fever. Also intravascular grafts. So people who have a AAA graft, that is a place where if exposed to Q fever are at high risk for becoming infected in their graft. You can get a full range of other infections with Q fever chronically as well. Osteoarticular disease, you can get meningitis and encephalitis, lymphadenitis, pericarditis, you can get a uveitis. All these things have been documented, but again, the most common form of chronic Q fever is the endocarditis and or prosthetic device infections within your body. And I also bring up, I will tie in a little bit of COVID to this talk here today. So for all intracellular infections, the treatments tend to be in antibiotics that target intracellular targets. So they're not typically your beta-lactams that have to do with cell wall growth. They're more intracellular protein synthesis targets such as doxycycline. So doxycycline is one of the backbones of therapy for most of the intracellular organism infections. Dr. Diderot is a big proponent of hydroxychloroquine. And so he studied hydroxychloroquine in intracellular infections for most of his career, and he recommends that as an adjuvant to treatment for many of these. The reason being that part of the defense mechanisms of these intracellular organisms is that they change the intracellular pH, which decreases the effectiveness of the antibiotics. Giving hydroxychloroquine helps to normalize the intracellular pH and offset that so that the antibiotics become more cidal and more effective. I bring this up because at the beginning of COVID, there was much debate about hydroxychloroquine, and Dr. Diderot was one of the early proponents that hydroxychloroquine would have great value in COVID. So I trust that he is right in Q fever, but clearly the evidence has not supported him with COVID. So next slide, please. So just before let me make sure I didn't forget any of my notes here on Q fever. No. So moving on to other infections that you can get intracellularly, the next most common one would be Bartonella. So Bartonella has risk factors in patients who are homeless, who have alcoholism, who have frequent exposures to cats with cat bites, scratches, and fleas. And this is all for Bartonella henselae, right, is the main cause of Bartonella endocarditis. You can get Bartonella endocarditis from Quintana as well, which is the cause of trench fever. That is transmitted by human lice and was first described in World War I in great detail and causes a relapsing fever that in rare cases can go on to endocarditis. And again, the risk factors that are listed really have to do with, your risk of exposure to the host organism, which are animals, and as well as a decrease in your immune system leading to more severe disease. And again, doxycycline being part of the core of this, and as a gram-negative organism, a strong course of gentamicin for several weeks, plus or minus ceftriaxone, and doxycycline as treatment of a treatment course sufficient for endocarditis treatment is the recommended course. Again, all these things that we're talking about now are really literature based in terms of what the ideal treatment regimens are. There's very little in the way of randomized control studies for these small number of cases that are out there. And much of the treatment recommendations are all based on expert opinion and small case series, because there's never been enough cases to do a true randomized trial. Next slide, please. Whipple's disease, another extraordinarily interesting disease, wide spectrum of symptoms, arthralgias, GI problems, neurologic manifestations, and ultimately endovascular and myocardial involvement that ultimately leads to endocarditis. Extremely difficult to diagnose because it's a very uncommon, and you have to think of the diagnosis before you can actually diagnose it. It is nearly impossible to grow in culture, but it has on occasion been done to the point that has been DNA sequenced, such that we now have PCR technology that is able to better diagnose it than trying to find somebody who can culture it. Again, this is an extremely slow growing organism. It takes years to develop symptoms, and it does not go away quickly. So Bactrim is the treatment of choice, trimethoprim based or cotrimazole, depending on where you are in the world. And treatment typically needs at least 12, if not 18 months of treatment. And all of these intracellular endocarditis treatments have a significant risk of failure and relapse. So back to Q fever, 4 or 5% of people, even up to 5 years later, can have relapses in their treatments because the organisms can be so resistant to that final stage of killing. Whipple's disease is no exception to that. Excuse me, next slide, please. Other intracellular pathogens that were found in this study, mycoplasma, so both Mycoplasma pneumoniae as well as Mycoplasma hominis. No one would ever expect an organism like Mycobacterium hominis, which can cause sexually transmitted disease, to be a cause of endocarditis, but the PCR and serologic data does support that it has happened. Like as I said earlier, brucella is a well-known cause of and well-documented cause of endocarditis on occasions, but here in this study of almost 1,000 patients, not a single case of brucella. So it really is a factor of not so much that it's rare, but what's the prevalence in the community. So in areas that have eradicated brucella from their domesticated animals, then obviously there's no transmission to human beings. But in those parts of the world that still have brucella as an infectious etiology and an infection that's in their domesticated animals, then it will occasionally transmit to humans. And again, brucella is an organism that is, again, these are all interrelated intracellular pathogens, and this is typically transmitted through unpasteurized dairy products, be it milk or cheeses, are typically the most common. And again, it produces a non-specific febrile illness. Most typically, it gives a osteoarticular infection, such as vertebral osteomyelitis, but on rare occasions can give you an infection in your heart. There are also chlamydia type infections, most notably chlamydia psittaceae, which is transmitted from birds, which has been shown to cause endocarditis, as well as on rare occasion Legionella, which again is a ubiquitous organism throughout the world. So next slide, please. A very interesting case of endocarditis, Mycobacterium bovis, right? So here we have a patient with bladder cancer who was given BCG bladder infusion therapy to cure their bladder cancer. And in that immunosuppressed host, on rare occasion, you can actually transform the BCG into an infection with a mycobacterium infection. So this requires systemic therapy, just like any other mycobacterium infection, for many, many months. So at least 6 to 9 months, if not longer, for any of your mycobacterium infections that are extrapulmonary. And so again, very rare, but well documented that this has happened on more than one occasion. So next slide, please. So there's possible to have non-infectious causes of endocarditis as well. So there's things not listed here are things like antiphospholipid syndromes and other autoimmune diseases related to lupus that can all cause fine vegetations on your valves that look like and mimic endocarditis, and obviously don't respond to antibiotic treatment. And in particular, 3 of the ones that were found in this study was a case of merantic endocarditis, which is endocarditis associated with advanced malignancy. So here, a patient with advanced metastatic prostate cancer who was found to have vegetations on their aortic valve as a result of their malignancy, with no causative infectious reason behind it. A second one, Loeffler's endocarditis, which is an eosinophilic infiltration of the myocardium. And in this case, the patient had an underlying hematologic malignancy and acute leukemia, right? And this is proven by biopsy as an extremely rare cause of endocarditis. And finally, one of the most interesting ones that I've ever seen is a person who had 4 prosthetic aortic valve replacements over the course of 2 years, who kept having febrile illness, who kept developing vegetations and thickening of their new porcine aortic valve, and allergy testing to pork turned out to be positive. And so here's an extremely rare example of somebody who developed an allergy to pork, and because they were kept putting in a pig valve into their heart, kept having a rejection reaction to that, causing them, and again, it took 4 times for somebody to figure out that it wasn't an infection that was causing the heart disease, that was causing the heart valve problem, but that was in fact an allergic reaction. So next slide, please. So that's the end of my presentation for today for discussion on culture negative endocarditis. And so I want to turn it over to the audience to let everybody ask any questions. And I guess thank you for having me here today.
Thank you, dear colleague, for this very interesting talk. And if there is any question in the audience, by chat or by activating your mic. Rashid, if you want to say something.
Yeah, okay. Brian, thank you for the excellent talk. I have two questions, Brian. The first one, I was thinking when you're talking about PCR, do you think there is any benefit in using PCR in patient that you are come with suspicion of endocarditis, that who came to the ER, they gave him antibiotic, then they send the blood culture later on instead of doing blood culture and waiting? Do you think that in patient who was already started on antibiotic, maybe PCR will can find certain like a bacteria you may
Yes,
not
so
see
that
in the blood culture?
right. So that yes, so that's exactly what the study is suggesting, is that for those patients who have received their antibiotics prior to getting their blood cultures drawn is a common clinical scenario where you end up with a culture negative endocarditis, but you're almost certain that they had a true, bacterial source, a regular traditional bacterial source. And normally the lab will not run the PCR on a negative specimen. But I am in fact going to start to approach the lab and say, in limited circumstances with high suspicion, is this something that we can do so that we can perhaps recover a few more cases and get a definitive diagnosis to better direct therapy. So yes, I think this is the wave of the future, is as these technologies become more readily acceptable in the community hospital setting, that we access them and make the most use of them.
And Brian, the second question, can you tell the audience anything about tuberculosis and endocarditis? Because in Algeria and North Africa, there's still area when you can see people with tuberculosis. Can you tell us just a little bit, if you have?
Right. So again, as far as I know, for regular Mycobacterium tuberculosis, the likelihood that that's going to cause endocarditis is extremely rare. So the one case that I did show was not MTB, but Mycobacterium bovis, and it was in an extremely immunosuppressed patient with advanced malignancy. So I think in general, there's no shortage of extrapulmonary tuberculosis out there, especially in endemic areas where some of you may be. But I would think that the likelihood that you're going, even especially in an endemic area, common things are common, and so the likelihood that you're going to find a true MTB endocarditis, I think, is extremely rare. So I think you would need a few extra clinical levels of suspicion to justify looking for endocarditis due to that organism, unless without looking for any other places first.
Thank you.
Brian, quickly, just one thing, just quickly on the PCR. I'm just thinking about how we can do PCR technology in Algeria. Is it costly? Is it expensive to have PCR, to do all the tests with PCR? And what's the cost involved? And is it complicated? Let's say North Africa or Algeria want to do it. How is it? Is it too many things that we need to do, or what?
Well, again, I think, like I said, it's becoming much more affordable. So I don't know what the international costs are going to be, because oftentimes they charge hospitals in the United States more than they will sell some technologies, just like drugs. They'll sell for lower cost to, say, Africa and African nations than they will charge the United States. So, for example, we doing PCR technology on blood cultures right now, it costs us about $120 per test to run the like a gram-positive panel on a positive blood culture with gram-positive. So if I have a blood culture that's positive, that says gram-positive Coxsackie clusters, and I want to know today that it's MRSA and not have to wait 2 days to find that out in terms of my treatment and therapeutics, we pay $120 to run the test one time. So depending on how much more economical it can be to buy it in Algeria, I'm not sure, but I bet they'll sell it for less than that.
Okay.
To you. But again, so that's just to put in reference, that's a lot of money to do that kind of test here. So
There
it's
is
not the kind of thing.
there is a question about Dr. Wadallah. You can ask your question, please. Saeed,
Yes.
ask your question.
Do you hear me?
Yeah.
Yes, I can hear you.
Yes. Now the sound is.
Thank you very much for your presentation, sir. My first question is, do you hear me? Do you hear me?
We hear you.
Because of diagnostic difficulty in a stable patient, is it possible to start probabilistic antibiotic therapy in the case of atypical endocarditis? I don't know if you do that in your clinical practice. To start antibiotic therapy in the case of high clinical suspicion of endocarditis, and you suspect an atypical one. My second question is, in the case of the response of to antibiotic therapy, do you consider that as a positive criterion of endocarditis? Thank you.
Sure. So the first call. So to answer your first question, I divided into two different categories. One is acute versus chronic. So if a patient comes in with an acute presentation consistent with endocarditis, meaning they have high fevers, they have acute change in their status, and you do echocardiogram and you see that they have a valvular vegetation, by all means, I would treat them broadly with antibiotics for typical endocarditis organisms like vancomycin and high-dose ceftriaxone or cefepime until you either ascertain a diagnosis or come up with negative blood cultures. The blood culture negative endocarditis organisms that we're talking about typically are causing a more chronic endocarditis that is not so acute. So they've been sick for a long time. And in that case, to add doxycycline, sure, you can do that early on, but you typically have more time to figure it out, and you're not going to have a negative clinical outcome if you wait a week in a patient who's been sick for a year to wait for your serology to come back to know what your true diagnosis is. So I think it depends on the clinical situation. The more acutely ill they are, the more broadly you're going to cover them, and the quicker you're going to cover them, as opposed to if they're presenting with a more chronic condition where you have time to better target your diagnostic testing to your therapy.
Okay, thank you.
There is a question, Brian, from a doctor. I'm not sure.
Dr. Abdul Baqi.
Dr. Abdul Baqi.
Can you ask your question, Dr. Abdul Baqi?
So I'm asking, do you think that PET-CT has place in diagnosis of atypical endocarditis? And do you think that it can be alternative of PCR? What do you choose if you have to choose between the two techniques? As it is functional imaging, do you think that it is benefit in diagnosis of atypical endocarditis? Thank you.
So I'm sorry, I could only hear about half of what you said.
About CT.
Brian, the question is, if PET scan can give you a diagnosis of endocarditis versus if you don't have PCR, you have both. What one you choose?
So CAT scan versus
PET scan.
PCR?
PET scan.
Oh, PET scan.
Yeah.
So PET scan is being used more and more for the diagnosis of endocarditis. So that is true. If you have access to a PET scan and they'll let you use that, by all means. So the PET scan is, an older technology in nuclear medicine used to be either a tagged white blood cell scan with indium or technetium. The sensitivity of that for endocarditis is quite low, but with new technology like a PET scan, by all means, PET scan, you'll certainly see uptake on a PET scan in most cases of endocarditis. So for that, the diagnostic sensitivity is fairly good. So especially for a chronic case of endocarditis where you're not quite sure where to look and you're looking more broadly, you're not just looking for endocarditis, a PET scan could be very helpful in terms of, you'll be able to ascertain a full body view of what may be going on with the patient and strike upon a diagnosis that ends up being endocarditis. So yes, I would certainly do them in conjunction, and especially as part of a chronic FUO workup. If you have access to a PET scan, that's still very difficult here in the United States to do. They don't like to do that very often to approve that. So for payment. So if you have access to a PET scan for it, I highly endorse that. Yes.
And in which cases it can be negative in endocarditis, in atypical endocarditis? Could be the PET scan negative?
Well, again, no test is perfect. So yes, it could be negative, but there should be glucose, abnormal glucose uptake, and because it should be hypermetabolic in whatever cells are infected. And so, like I said, I think there have been some studies done on endocarditis and PET scanning, and I do believe the sensitivity is probably in the 80-ish% range, if I recall correctly last time I looked at that. So yes, you still may miss 20% of cases, but that's still pretty, in terms of diagnostic testing, that's pretty good.
Thank you.
Is there any other questions in the audience?
I have a question. If there is a Brian, what are the indication of someone who has prosthetic valve and has endocarditis? So most of the time is surgical. You need something for surgery. Do you see anything not surgical? If we exclude the patient who are very sick and they can't go to the surgery, any other entity that you may be able to treat just with antibiotic long term versus sending this patient for surgery?
Right. So yes, if you have prosthetic valve endocarditis, most times they're going to want to take out that valve if they can. Again, when we say that, there's a large majority of patients who they find a reason why they're too sick or too old or too debilitated, and try and treat through. And I see fair success in treating prosthetic valve endocarditis without removal, a fair number of times, and so it's not as uncommon as you might think that people have to treat their endocarditis, and much of that time we'll leave those kind of patients on indefinite suppression therapy for whatever it is that you're treating, and most times you can help people live for a good long time without having any sequela.
Thank you, Brian.
Thank you. Thank you very much. So if there is no question in the audience, so thank you very much for your presentation, and I hope
thank you for having me. I appreciate it very much, the invitation.
Okay, we hope we will have you again and meet you again in the next future.
Okay.
Thank you very much, Dr. Dawi.
Thank you.
Anything to Dawi, Rashid?
Yeah, I would like to thank Dr. Brian on my name and the name of the attendee and the name of all Algerian people for your excellent presentation. And we are looking forward to see you again and to hear from you again in one of the topics that maybe you can present.